Good evening, everybody, and welcome to the Prostate Forum. We are honored and pleased to welcome back Dr. Jeremie Calais, who is a researcher and a practicing physician at the University of California, Los Angeles campus. For those of you not familiar with UCLA, it is in the West Los Angeles region of California. He is a researcher that specializes in something called Theranostics, which is a radiopharmaceutical agent that both detects metastatic cancer and, I want to say, inactivates it. It doesn't really destroy it, and the doctor will talk about what these radiological agents do to help you with metastatic prostate cancer. Dr. Calais' work focuses on improving the outcomes of cancer patients' treatments by translating and applying novel diagnostic and therapeutic approaches. He used positron emission tomography, computed tomography, PET/CT imaging for cancer phenotyping, radiation therapy, planning, treatment, and therapy response assessment. He leads the clinical theranostics research program at UCLA that combines radionucleotide therapy and imaging.
First, a quick word about the Prostate Forum. The Prostate Forum has been active for more than 30 years, offering information, education, and hope to anyone affected by prostate cancer. We host online support groups twice a month on the second and fourth Tuesday. These sessions provide a safe place to share experiences and support each other. To stay informed about upcoming meetings, simply register on our website, prostateforum.org. On the fourth Tuesday of most months, we offer special presentations just like this one, featuring leading experts in prostate cancer. These sessions provide valuable insights and the latest information on treatments and research, helping you stay informed and empowered. You can find almost 100 previous presentations on the website at prostateforum.org/presentations. And if you subscribe to this YouTube channel, you'll be notified when new presentations are released. Finally, remember, you can make a difference. The Prostate Forum is an all-volunteer organization, so we always can use your help to help others. Consider volunteering your time or making a donation to support our work. Your time and expertise can be used to organize support, for outreach, for content creation, and for website maintenance. And your donations help us continue to provide these vital resources and support services. Visit our website to learn more about how you can get involved, make a donation, and have a positive impact.
Thanks for this kind introduction. My pleasure to be here again, back, and give some updates on what we do in Theranostics here at UCLA. Okay, so again, my pleasure to be here and give some updates. I think it's maybe the fourth, fifth time I'm here with you. I think the first time I did it, it was in person in Fullerton, near this church, or in the church, which was an interesting experience with Dr. Auerbach. And so since then, many things occurred in the theranostic space and the PSMA theranostic space. So today I was asked by the Orange County Prostate Cancer Patient Forum team to give some updates on what we do. So I will give some refreshers, but mostly I will focus on what is new. Just to show here our clinical research program focusing on PSMA targeted therapy. We were one of the first sites in the US to start lutetium PSMA treatment, so PLUVICTO. You can see here the name and the numbers. That was in 2017. Some of you may have participated in these clinical trials that we can see here. And you can see that we continue to try to further refine the use of the agent, answer new clinical questions, and move at early disease stage the treatment. PLUVICTO got approved in 2022. And since then, we have treated outside of research per standard clinical care about 150 patients up to now. There is a huge interest and dynamism in the nuclear medicine fields, and Theranostics is really booming. You can see all these growth curves. You can see here multiple radiopharmaceutical on even any big pharma company trying to jump into the theranostic space and pushing compounds to, approval and further in the clinical research development. It is for prostate cancer, but it is also for many other cancers using PSMA, but also, again, many other targets. And that's how we were doing it up to last year. So from 2017 to 2023. So some of you may have been there receiving PLUVICTO. But as I just showed, as the field is really booming, as there is a increased volume of patients, and we anticipate to have much more, we had to expand. So we built a new Theranostics suite, a radiopharmaceutical therapy dedicated center at UCLA. It's an outpatient center, and we opened that just earlier this year. And so that's where we do our PLUVICTO treatments now. You can see here the leadership, and that's my boss, Johannes Jernin, nuclear medicine physician leading the department. So some quick refresher about what we're going to talk about today in nuclear medicine. So nuclear medicine is the use of radiopharmaceutical for medical purposes. Radiopharmaceutical are radioactive drugs, and you can do two things with that. You can do either imaging, or you can do therapy. And the imaging ones, you inject them in very tiny quantity. So that's why we usually call them tracers, because you can trace it, you can detect it, because it still emits some radiation, which is a physical mechanism that is very reliably, that we can measure very reliably, and even in tiny quantity. But it's injected in so small and tiny quantity that it doesn't have any effect on the body. So that's why we call it a tracer. You can trace it, but without any effect pharmacologically on the body, which is different than contrast agents, for example. Here I put the most commonly used PET tracers. So today we're going to talk about PSMA, but it's just to put a refresher. Molecular radiotherapy, or radiopharmaceutical therapy, or radionuclide therapy, or radioligand therapy, or peptide receptor radionuclide therapy. All these, they pretty much mean the same thing. It is a radiopharmaceutical agent that you inject that has different physical properties than the one we use for imaging, because they this time emit beta radiation instead of gamma radiation. And the beta radiation, they don't travel very far where it has been emitted, and only a few millimeters, and they deliver a lot of high energy. So here we inject much higher quantity, much higher activity, much higher dose, and the radiation will, remain close to where it comes from and deliver a lot of radiation, and it can kill the cell by inducing DNA damage. So it's kind of doing radiation therapy, but at the molecular level, at the cellular level, where the radiopharmaceutical agent is being accumulated. And here today, we're going to talk about PSMA, of course. PSMA is that protein that we use as an anchor, that protein that is overexpressed by prostate cancer cells that will attract the radiopharmaceutical, and the radiopharmaceutical will bind then to the cancer cells. This is another way to put it. And so that's where the word Theranostics comes from. Thera from therapeutic, gnostic from diagnostic. And so it's the combined use of an imaging agent and a therapy agent that both have the same molecular target. And today we're going to talk about PSMA, but again, there are other approaches like that. In PSMA PET got approved by the FDA in 2020, and lutetium-177 PSMA therapy got approved by the FDA in 2022. So this is a successful approach of Theranostics that targets PSMA, and now that went from clinical research to really FDA approved techniques. Here is another way to see a little bit how it works. Lutetium PSMA. So lutetium-177 is a beta emitting agent. I show that here. The half-life is 7 days. So it means that after 7 days, you have only half of it that remains. The other half has decay. That's the radiation emission. And what you can see here is the images of the treatment itself. There is, in fact, 15% of the radiation that are not beta, but also gamma coming out of lutetium. And so you can detect this gamma with SPECT-CT scanners, the same scanners you use to do, for example, a bone scan. And you can create images of you directly from your treatment itself. And here you see the images over time, 4 hours, 24 hours, 2 days, 5 days after treatment administration. You can see how the circulating radioactivity decreases over time from the blood going to, in the urine, excreted by the kidney into the bladder, and only remain the radiopharmaceutical that has been trapped into the cancer cells and therefore irradiate continuously the cancer cells, as you can see here. And this effect will occur during the 2-3 weeks following the infusion of lutetium PSMA therapy. So that's how it works. And this ratio, this differential amount of radiopharmaceutical in the tumor target versus almost nothing in the normal organs after, several days, that's what we use for treatment. We deliver a lot of those in the treatment targets and not a lot in the normal organs. That's why it's well correlated in comparison to chemotherapy, because it is this targeted approach. But each patient will react differently, of course, to the treatment, depending on how the disease burden is in each patient. You will have different types of response. Depending on how the PSMA target is expressed by the lesions, you will have different types of response. And you can estimate basically the distribution of the treatment that we see here on the corresponding PSMA PET scan before. It gives you a nice estimate of that. And so that's what we use to, select or non-select patient for PLUVICTO treatment. I think at the end, we use it mostly to identify the patient who are really unlikely to have a good response, instead of selecting only the patient with a very good likelihood of a good response. We still, give a good chance. Imaging is not everything, so you still have some patients that may benefit from the treatment, but at least it allows to really define the patients who are very unlikely to respond and for who we should offer something else than a PSMA targeted approach. What you see here is a different scoring system, different methods to try to estimate the likelihood of response to the therapy based on this initial baseline PSMA PET scan. And of course, quite instinctively, the more you have lesion black on white like that with a lot of PSMA, a lot of expression, the more you will have radiopharmaceutical delivery. And so the better would be the response homogeneously. And the more it gets heterogeneous or with low uptake, the less response you're going to get. But that's a continuous, pattern. There is no real cutoff. Okay, one question that comes quite often now is, with the availability of different PSMA PET tracers, UCLA, UCSF were the first one to get an FDA approval for PSMA PET. We manufacture our own here at UCLA, gallium-68, PSMA-11, and each manufacturing method is FDA approved. Following that, 2021, 2022, multiple commercial vendors came on the market with other PSMA PET agents. At the end, they're pretty much the same. They all show where PSMA is expressed at a similar level. There are tiny, subtle differences, but let's say as a general rule, for large patient cohorts, we don't see really major differences between all these agents. Of course, you, like always in medicine, you always have some stories here and there, you know, showing the superiority of one agent over the other in one patient, and then vice versa in the other. But at the end, if I have one take-home message to say, is that among these various agents, it's pretty much the same thing. And the impact on clinical management is quite the same, whether you use one agent or the other. And the guidelines are reflecting that, you know. We try to just adapt a little bit the guidelines in terms of rules we use to select patient to PLUVICTO. So classically, the liver was the organ of reference we use to grade the uptake in the lesion in comparison to the liver uptake. But for example, PSOLUMA, which is a recently approved PSMA PET agent, has on a normal basis a higher uptake in the liver. So here we have to take that into account. Here is data looking at the responses of patients who were screened with either PYL, PYLARIFY, or gallium-68 PSMA-11, and then were treated with PLUVICTO. You can see that it's pretty much the same. Here is data comparing PYL and PSMA-1007. PSMA-1007 is only available in Europe now, but it may come one day in the US or not. But just that you know that there are other PSMA PET agents also available outside of the US. And again, you can adapt a little bit the normal organs ratio, but at the end, most of the guidelines and the expert committees, they consider this tracer equivalently. Now there is the question of FDG. So FDG is fluorodeoxyglucose. It's a glycolytic tracer. So basically it shows where the glucose metabolism is occurring in the body. And for example, that's an image that we see here. Why do you see in black the brain like that? Because the brain consumes only glucose. So that's why you have all this sugar here. And cancer cells, they do consume a lot of sugar, specifically when they become aggressive. That's how they grow. That's how they thrive and progress. And in prostate cancer, specifically when patients get metastatic, more and more lesions become more and more aggressive. And here FDG can help to show where these lesions with aggressive patterns and phenotypes can be. And usually when the more you have FDG positive disease, the worse the prognosis is in terms of response to treatment. So we also use FDG whenever possible to get more information before choosing the next treatment. And we know that these lesions that are FDG positive, PSMA negative, will not respond well to lutetium PSMA therapy. And so here we will probably suggest to do something else if there are potentially other options. Whether we see them at baseline or if they arrive or if we see them during therapy, in both of these cases, it's not a good sign. So for example, in Australia, they use this combined approach of PSMA and FDG before every lutetium PSMA therapy consultation. And if there was too much mismatch between the two patterns, again, FDG positive, PSMA negative, then they would refer the patient to another treatment approach than lutetium PSMA therapy. So people have tried to look at if it was really necessary to do an FDG in all patients, because it creates problems, right? You need to have this insurance covered. It's a second PET-CT appointment. You have dual reporting. So it can also create, troubles to the patient flow. And so people have tried to look at if it was really necessary, like how many cases would not be treated. And in that study, for example, there was mismatch only in less than 5%. So I would say, of course, if you try to reproduce the results of that study. You may find different numbers depending on the cohort you're using. But at the end, the take-home message is that, yes, FDG can be very informative. Now, I don't think that it is required to be treated with lutetium PSMA therapy. So if you have friends, patients around you that are considered for lutetium PSMA therapy, that you can tell them to do an FDG PET scan if feasible and easy to do. If it's a lot of constraints, then it's okay to not do it. And beyond the baseline PSMA PET scan, Theranostics approach and selection, I think the best information we can get from whole body PET imaging is actually the sequential information over time. How these images, they evolve under treatment over time. Here is a nice illustration of a patient with massive disease, metastatic disease, responding very well to the treatment. Each red arrow that you see here is a PLUVICTO cycle infusion. Here is the PSA curve decreasing nicely, and you can see PET scan done subsequently between several cycles with the decreasing number of lesions over time. So very nice example of sequential PSMA PET imaging. What is important to know is that if you started with one tracer, for example, gallium-68 PSMA 11, you cannot really be evaluated with another PSMA PET tracer, PSOLUMA or PYLARIFY. I think to really assess the response to therapy, you have to stick with the same PSMA PET agent. That's important to know. Otherwise, you can still evaluate a little bit, but you have less confidence in any change you can observe if it's not the same tracer that you're using. We start to have now sufficient data to start to generate some rules on how we interpret the response on a subsequent PSMA PET scan. RECIPE criteria have been established now, and it basically combined two parameters. The whole body volume changes. So here you can see in red, increase of the tumor volume. Here you can see, for example, in green, decrease of the tumor volume, and combined with the apparition or not of new lesions. And by combining these two information, we are able to identify 3 patterns of response that correlate pretty well with the final outcome of the patient and the treatment. And so now we're trying to use that more and more in clinical practice. PSA, of course, remains an excellent tool to measure response. It's easy to do, it's a blood test, so easily accessible, cheap. So we use PSA a lot as well. Here are various PSA response patterns under lutetium PSMA therapy. You can see in yellow, again, each treatment cycle. And you can see that you have really the patient that respond very well, the patient that never respond well, and all the intermediate response patterns in between, where you have flattening of the curve, some response but not complete, initial response but then ultimately progression, all type of different response patterns. So not everybody responds the same. But still, the way the PSA changes under treatment is really well correlated at the end with the overall outcome. In this is from the VISION trial, so the main trial that was used for the approval of PLUVICTO. And they looked at different PSA response. When patient had more than 90% of PSA decline, you can see how the survival curve is good. On the inverse, when patient never had any PSA decline, these patients tend to progress much faster. And like I showed you initially, when I tried to explain a little bit the mechanism of action of PLUVICTO with lutetium-177, you can create images from the drug itself. So a new approach now is to have the patient come back 1 day or 2 days after the infusion of each PLUVICTO cycle. Under a camera, again, it's a gamma camera, a scintigraphy camera, the same camera that you use to do a bone scan, for example. And then you can image the radiopharmaceutical treatment itself, PLUVICTO. That gives you a good estimate of where the treatment went, gives you a good estimate of how much is the disease burden and how it compares over time. And so you can really, at each cycle, evaluate the disease burden and monitor the patients with SPECT-CT. So now we're trying to do that more and more. And by combining this information with the PSA, so the SPECT total tumor volume with the PSA, you can really have different response patterns that you can use for treatment management. And now it's, for me, a good transition to introduce the 2 new studies that we're opening based on these principles. So as a quick refresher, PLUVICTO was approved with the following treatment administration scheme. Up to 6 cycles, no more. And between each cycles, it's 6 weeks. And it's a fixed injected activity of 7.4 gigabecquerel. That's how it has been shown to be efficient in the pivotal clinical trial. And that's great. It got approved like that. But we think we can go beyond that. Many patients in Europe or in Australia, they receive more than 6 cycles. Here is a patient story of a patient who got 16 cycles over 15 months. You can see how the burden of the disease was super high at the beginning, received 4 cycles, responded extremely well. Then they paused, disease came back, and then they retreated again, and again the year after, and again. And so the patient was really able to push back further the progression of the disease with subsequent retreatment or rechallenge series of PLUVICTO. And this patient tolerated pretty well with very low toxicity profile. And so now at UCLA, we want to generate prospectively the data for the FDA, for Novartis, to show that you can expose patients to more than 6 cycles safely and with some clinical benefit. So the study is now open. We opened it the 1st of August. And it's for patients who had initially a good response to PLUVICTO, to their first 4 to 6 cycles. And then they reach the limit of 6. And here we can provide the opportunity to get another round of 6 cycles after that. Furthermore, we're going to do SPECT-CT imaging at each treatment cycle. So it gives, you know, a nice insight on how the patient is behaving under treatment and more information and close monitoring of the treatment response. And so that study is open. So I'd like to take the opportunity to present you that study here, this patient forum group, to communicate on that study now open. If you know how I can even communicate more about it, have a larger, patient audience that everybody's aware about that, please tell me and help me to communicate about that study that we have open at UCLA. Other than that, you know, across in the US, I know some sites manage to get more than 6 cycles of PLUVICTO. And for now, Medicare sometimes is covering these cycles, but private insurance will deny it for sure. It's outside of the label, and many centers, they don't do it. So here, I think it's a great opportunity for patients who have initially a good response to PLUVICTO. These are, you know, some details of the inclusion-exclusion criteria. I will skip that and invite you to contact me and send me info if you're interested. Again, some contact info. Now I'm going to introduce a second concept, which is the treatment holiday concept. Treatment holidays. So, for example, that story of a patient who received 20 cycles of PLUVICTO from Australia. Each red arrow is a treatment cycle. you can see that initially patients receive 6 cycles with a great PSA decline. And then they pause the treatment, waited that the PSA comes back again, retreated with 3 cycles, and again after the next PSA progression, and again and again. And with that, they were able to get, 4 years, 5 years at least of progression pushback. And it's unclear what would have happened if the 20 cycles of PLUVICTO would have been administered all at the same time here. Maybe here we would have some toxicity issues. Maybe we're giving them for nothing because there was no disease to treat anymore. So that's period between when you don't see any disease anymore, when the PSA is low, between 2 regimens, it's called a treatment holiday. And that's really offer, some comfort to the patients and keep the opportunity of receiving more PLUVICTO cycles for later. Here is another study that look at 2 groups of patients. So each dot here, each line is a patient. And you can see the more you go on the right side, the more time has been spent. Each dot is a treatment cycle. And so you see here a group of patients that received here either treatment cycles consecutively and then nothing. That's what we see in blue. Or treatment cycles with different time intervals between the treatment cycles. And these are the treatment holidays period. And you can see that that group at the end, by pushing back the time of the next progression again and again, you're able to have better survival curve in that group. So that's what we're going to try to replicate in a prospective clinical trial here at UCLA. We're going to monitor patients with SPECT-CT imaging at each cycle. And depending on how they respond, combined with the PSA response, if patient has an exceptional response, which occurs, in about 15% of patients, I would say, then we will tell them, you don't need to be treated anymore now. Let's wait, monitor you only. And if ever the disease is coming back, then we will retreat you. And with that, in some retrospective studies, a patient like this who has a great PSMA decline observed on SPECT, a great PSA decline, we would offer a treatment holiday period. A patient like that that has intermediate response, we continue to treat. And a patient like that that is progressing too much, that we don't see any type of response, we discontinue treatment. You can see by using these 3 patterns of response and either pausing the treatment, continue the treatment, or discontinue the treatment, you're able to really create 3 groups of responses. And it seems that this can be well correlated with ultimate outcomes. So the study is open now. Also, we opened earlier this month. It's a randomized trial, so patients get 50% chance to either be randomized to the control group, 6 cycles of PLUVICTO at a fixed time interval every 6 weeks, or they get 50% chance to be randomized to the investigational group, where they can receive up to 12 cycles of treatment, and with the possibility of treatment holidays based on SPECT-CT monitoring. So again, I think any patient that is now considered for PLUVICTO treatment should highly consider that study, because there is no reason to not do it. You get closer monitoring with SPECT-CT, and you get 50% chance to potentially get up to 12 cycles if ever you respond well. So please communicate about that study. Think about it if you have a patient asking and friends asking for PLUVICTO centers. This is the figure representing the 2 treatment arms, the contact info. And I think I will pause here because I prefer to answer questions than just talking alone with my slides. So feel free to ask any questions.
I know, Dr. Metzger, you have a few questions. Would you like to start us off?
Yeah, I can. I'm having trouble with my computer. I'm on my iPhone. Can you hear me?
Yes.
Well, thank you very much, Dr. Calais, for this talk. This is a very confusing topic to us, not only because it's new, but because it's hard to figure out who would cover, who can have it, who can't have it. We have a specific question, though, about, and I think you kind of answered it, but when one agent or ligand doesn't detect, is it worth doing another one to try and figure out whether a elevated PSA is a recurrence if the initial one is negative, or is that just wasting a lot of money?
Wasting money is likely. Now, if it's for free, why not? But I
Yes.
will give you many information. Then you have to understand that there is no strict rule and strict answer that fits every cases. So, for example, PSOLUMA or HPSMA is maybe better for all the lesions that are just below the bladder. So at early disease recurrence stage, for patients who got initial surgery, for example, unfortunately, the PSA is coming back. They have biochemical recurrence, but the PSA is still low, 0.3, 0.4, 0.2. You do a first PSMA PET scan, there is nothing. First, it's a good information. It's better to have nothing than something, right? The less you see, the smaller the disease is, the better it is for patients. So it's a good news. I want to emphasize that message. You should not be disappointed if we see nothing on a scan. It's better to have nothing than something. When patients are being treated and you compare the patient who had a negative scan or a patient who had a positive scan, the patient who have a negative scan, they do better than the patient who have a positive scan. So that's good. Now, if your urologist or radiation oncologist really want to find a target to potentially irradiate it, strongly believe that only 1 or 2 targets are responsible for the PSA increase. It is possible that PSOLUMA shows better lesions that are just below the bladder in the prostate fossa, such as MRI. So maybe on a one case-by-case basis, it may be relevant, but I think the main trigger to redo a PSMA PET scan using one agent or the other is the PSA. I think you need to wait that the PSA is increasing more if you want to have a positive scan. Now, we should not use too much PSMA PET imaging to de-escalate treatment management. If a radiation oncologist wanted to irradiate the prostate fossa, the prostate bed, blindly, even without any evidence of visible disease there, you do a PSMA PET scan, the PSMA PET scan is negative, you must do the treatment. You cannot say, we didn't see it on PSMA PET scan, I will not do the treatment. It is not like that. PSMA PET is good. You can show a lot of lesions that was unseen before, but it's still not showing the microscopic lesions. You cannot see them. So not to be used for de-escalation of therapy. So when a patient has a PSA of 0.3, has a negative PSMA PET scan, either the physician wants to treat with radiation therapy, for example, and should, or they want to hold, but what will happen if the PSA goes to 0.5, you can redo the PSMA PET scan. It increases from 0.3 to 0.5. It is worth doing another PSMA PET scan. You can see something maybe, but you have to understand the risk that you also let the opportunity to the disease to progress and become visible.
Yeah. Is the status of the copper ligand, is there making any advances with that?
Copper 64 is different than gallium and F18 because it has a longer half-life. It means that gallium-68 is 1 hour half-life. After a couple of hours, there is nothing anymore you can see. Everything has disappeared already. Copper-64 is 12 hours half-life, so you can do late imaging. It means you can inject the tracer and almost do imaging the day after, you will still see something, which gives the opportunity to have more time to have the PSMA tracer uptake trapped in the cancer lesion and decreasing uptake in the normal organs. And so you have this differential ratio that sometimes, enables better visualization of lesions at late time points. So Copper-64 gives the opportunity to have late time point imaging. And at late time point imaging, you can detect more lesions because you have decreasing signal in the normal organs.
Yeah. What is the status at UCLA of the PSMA directed metastatic treatment?
We had a study where patient got limited amount of metastasis, 2, 3, 4, and they were both irradiated and treated with lutetium PSMA therapy. That was the LUNAR trial led by Dr. Kishan. This trial has completed the recruitment. So now at UCLA in oligometastatic disease stage, patients usually, based on the medical oncologist, the radiation oncologist, they would get usually quite an aggressive approach with the combination an AR targeted agent, hormonal therapy, and radiation therapy targeted to the metastasis.
Fantastic. Well, thank you very much for an excellent presentation. It's, as I say, seems to be where the future is, and yet it's hard, a little bit hard to understand how it fits in, especially in the low PSA patients. But
in the low patients, it's all about the expectations. The PSA is low, so the disease is super small. So what do you do with that? We don't know where it is exactly. You have to weigh the pro and cons of being treated or not. The only thing you know is that the PSA is low. And PSMA PET can show sometime lesions, but it's still far from perfection. So it's really understanding the expectations you can have from that.
yes, very good.
Well, thank you, Doctor. I have a couple of questions here. One from Bob we're all very concerned about. Has any progress been made towards preventing the side effects of the salivary glands?
No, there is no progress. It's a limitation because for example, we have another radiopharmaceutical therapy agent with actinium targeting PSMA as well, which deliver even much higher radiation, much higher energy, which is good, but has too much toxicity on the salivary gland. And so far, there are many research going on, trying to change a little bit the structure of the ligands so that they go less to the salivary gland and more to the tumors, trying to have concomitant, drugs that block the salivary gland uptake. People are trying various things, but so far, there is no good one. And that limits the use of actinium PSMA. However, for PLUVICTO and lutetium, people do report, dry mouth and, discomfort in terms of saliva. But from what I feel, I never experienced it, so I cannot say. But I feel it's still manageable for most of the patients. They are okay with that.
Yeah, but you're too young to know this, but but we used to radiate the breast before we gave men hormone ablation. Is there any way you could do that to the salivary gland?
Well, you want to keep the salivary gland function. You need your saliva.
Well, maybe a light dose of radiation?
The side effect on the salivary gland is because they have been irradiated by PLUVICTO. So you don't want to irradiate more.
Well, that wasn't a good idea.
I have another question for you that I think is close to one I've been wanting to ask. If BCR oncological activity is identified through a gallium-68 PSMA-11 PET scan, how is the decision made to treat the patient with conventional radiation versus Theranostics? What are the key drivers? Which is something I was going to ask is, please tell us, what is the ideal patient for gallium-68 Theranostics or anything else that's identified? Who should be seeing?
When the disease burden is low, so still in the biochemical recurrent setting, different than, very metastatic, lutetium PSMA therapy is not the best approach. I think Theranostics lutetium PSMA therapy is appropriate for patients with metastatic disease, with a lot of lesions that cannot be treated with conventional radiation therapy anymore. Otherwise, if you have one or two spots, it's better to irradiate them with conventional radiation therapy than lutetium PSMA radiopharmaceutical therapy.
Yeah, doctor.
Yes.
Can you hear me?
Yes.
For a negative PSMA PET CT in recurrence, can you hear me?
Yes.
In recurrence, negative PSMA PET CT, PSA of 0.75. At what PSA level would you recommend the next PSMA PET CT?
0.7?
Right now, yes.
That's
Negative PSMA PET CT, 10 years post-surgery, very slow. Where would you recommend the next PSMA PET CT?
So here, for example, the PSA is not so low. 0.7, at this level, usually PSMA PET scan can pick up things in up to 50 to 80% of the cases. Here can be good to change PSMA PET tracer just to see. So I don't know which tracer was used in your case or the case you're mentioning.
Yeah, PYLARIFY.
PYLARIFY, maybe you can try PSOLUMA somewhere and wait that the PSA is 0.8 or 0.9. But if PSA stays at 0.7, I think I wouldn't redo the scan now, specifically when it's slowly evolving over 10 years. So the doubling time is correlated also with the positivity of the scan. The slower the disease progression is, the less likely you are to see something on the scan.
Okay. So, for example, there is a trial on the copper PSMA PET CT in
That's
California.
I think that's a good one for that.
Okay.
I would recommend it, yes.
Okay. Thank you.
Anybody else like to ask any questions? Oh, Nathan. Hi, Nathan. Go
Hi,
right
guys.
ahead.
So, I think they use a vasoconstrictor in dental anesthesia to keep the anesthetic around the tooth for a longer time. Could you use a constrictor to protect the salivary gland?
Yeah, I know some people are trying that a little bit. We have to see how can this be implemented on a large scale. And it seems that, PLUVICTO is working as it is. Patients are reporting but not complaining too much overall of the salivary gland toxicity with the current PLUVICTO. And I think the salivary gland issue will be more of concern if actinium agents come closer to clinical approval, which is not the case yet. But yes, vasoconstriction can work, although the radiopharmaceutical is circulating for quite some time. So you need something that vasoconstricts and reduce the blood flow in the salivary gland for 24 hours. And yeah, something like that may work. Not easy to implement on a large scale though.
And no success with cold compresses or anything like that.
called, you mean ice packs?
Yes.
Some people are doing it specifically. It was done like that in Germany before. All the studies that try to demonstrate an objective effect failed to demonstrate that. But I don't see a good reason to not do it. If patient wants to do it, I think that's fine. You can ask. So what you do, you would start the cooling a couple of hours before treatment, be treating with the cooling and keep it for a couple of hours after, and that reduce the blood flow. Now, I think it's not easy to implement as well. And yeah.
Thank you very much, Nathan. Adam, please unmute and let's go to your question.
Hello, thank you very much for all the information. I arrived late today. I'm sorry I couldn't make it on time. I'm curious right now, I have, I'll just read off of here. I had a PSMA done this March 6th, notable subcenter foci PSMA uptake in the right external iliac region, max SUV 13, and the right pelvic sidewall, max SUV 6. And they've always recommended or wanted to go with the deprivation therapy and then radiation. What I'm wondering is that since I've been it sort of recurred and that the radiation, the oncologist said that because of where it is in relation to my rectum, that he wouldn't be able to give it the amount he would like to give it. So I'm always questioning, so is it going to help me? Am I going to have, more problems, down in that area than the success of whatever might be done, if that made sense. I'm sorry to sort of go around it. I don't quite know how to succinctly say it, but if he can't do what he really wants to do, it seems like it's sort of a halfway job. Thoughts?
Yeah, I think you put it the right way. Now, there is no miraculous solution. He cannot, take the risk to burn your rectum. So he has to decrease the dose, and you have to understand that not the full dose would have been given, and so the risk of recurrence is a little bit higher. That's one thing. Then it's about, shared decision. Once you know that, how do you live with that? What do you prefer in terms of risk? That's, at the end, I think it's personal decision. Some people want to say, okay, I don't want to take any risk from my rectum. It wouldn't work anyway because it's not full dose. I don't do it. Some people would say, okay, let's try it, and maybe I have some chance that it still work. And then,
Yeah, I think that's where my issue comes is, sort of the quality of life in relationship to the number of years.
We cannot anticipate what's going to happen exactly for you. So
No, exactly. That's what I'm saying. So if, let's just say I do end up with pooping problems for whatever reason, and my erectile function doesn't come back the way it is now, then again, I know it's my decision. I'm just saying in relation to what it is. And again, I came in very late today, but when I saw that you were talking about recurrence and that kind of trials, whether that was something that would be something to look into based on where it is and what it is.
Let me put in the chat a trial that may be of interest to you at UCLA.
Okay.
A radio-guided surgery trial. So it's to remove 1 or 2 metastases by surgery. It's appropriate only if there are not a lot of metastases, which seems to be the case, but we'll need to review the scan.
Mm-hmm.
Adam, have you had an evaluation for SpaceOAR in your case?
SpaceOAR, no. He always did this particular physician is just, you're playing with fire. You got to get started. Go get the Lupron shot. Let's go. You got to go. You got to go. I'm like, whoa, time out here. So no, so what's it called?
Well, I'm not sure if SpaceR is a gel that's injected to move the prostate away from the rectum to prevent rectum damage. I don't know if it'd be possible to do a similar thing with your situation or not.
Well, only because the prostate has been removed, so I don't know if that's moving anything
Yeah,
away.
because I don't know if you know exactly where the lesions are. Could you
Oh,
push them away from the rectum with a SpaceR? I don't know.
okay, a spacer. Thank you so much. I will look into that. All right, I just clicked on that. So thank you very much, doctor. I appreciate that very, very much.
Yeah, you can see look at this trial. Maybe it works.
Thank you very much.
I see a question from.
And thank everybody. Thank everyone
Oh,
as
thank you for
always.
coming, Adam. I see a question from Michael about PSMA and FDA approved and Dr. Kwan over at Mayo Clinic. And I see Dr. Calais where you've posted an answer. And maybe, Michael, we can get you to unmute and kind of clarify what's going on there and if this question has been answered.
Yes, right. It has been approved for metastatic castration-resistant prostate cancer, which failed one regimen of chemotherapy at minimum. There are 3 trials, PSMA-4, SPLASH, and ECLIPSE, that try to demonstrate the efficacy of the treatment in patients before they are being treated with chemotherapy. And I think this is going to happen. We can expect to have that probably during 2025. So for pre-chemotherapy, patients who never tried chemo, they do have metastatic castration-resistant prostate cancer, then I think they will get access to the treatment by the end of 2025. That's my anticipation. Now, before castration resistant, that's more unclear. I don't know. There is the PSMA addition trial that has completed recruitment, but the disease stage is much earlier, so to have mature data, it will take much more time. And if ever it is successful, that will be at least, 3-4 years from now.
Michael, did that answer your question?
Yes, I think Dr. Kwong argues that the way that the kind of SOP goes now, we try to slow the growth and spread of prostate cancer cells. But this allows the cancer cells to mutate and makes it much more difficult to then get rid of them. And I think his notion was that if we could kill a lot of them earlier, we have fewer problems with them mutating and becoming, different kinds of creatures we need to get rid of.
Yes, that's the theory. That's for sure.
Okay. Thank you.
Well, I want to thank all of you for coming because your live participation helps us a great deal. I think sometimes one of the most interesting parts of these presentations is what patients bring in their concerns and their hopes and what they're looking for in a treatment outcome. And don't forget, we have 2 support groups every month at Prostate Forum. They are 100% on Zoom, so you can attend anywhere in the world. Those support groups begin at 5 p.m. at the 2nd and 4th Tuesday of each month, 100% on Zoom, and that is Pacific time. You can find out more about Prostate Forum by visiting us at www.prostateforum.org. Peruse our website. You will find a section there called Join Us. We encourage you to put in your email so you can get regular announcements from us about presentations like the one you saw tonight, our support groups, and our special programs as well, and programs in the community that can help you and help other prostate cancer patients. Dr. Calais, I thank you very much for your time. I thank everybody here for their inquiries, and I look forward to seeing you in future presentations and at our support groups. Have a great night.